Behind every smile, there can be a silent struggle. Eating disorders are not just about food, but they're also about control, fear, and the search for self worth. So, good day, everyone. Good day, Ma'am La Vista. So, I am Erin Helena Ureta, and together with me are Mr. Kabatingan, Miss Arceo, and Miss Isaga. And today, we'll uncover the reality behind this hidden battle that affects both the mind and the body. So, welcome to our presentation entitled Care of Patient with Eating Disorders. Okay, so what is an eating disorder? So, eating disorders are serious mental health conditions that affect not only how a person eats, but also how they see and feel about their body. So, these are not just about food, but they are also deeply connected to a person's emotions, self esteem, and mental well being. So, as nurses, we play a vital role in helping patients recover. So, it is our responsibility to go beyond physical care. So, we provide education, emotional support, and guidance that can help individuals rebuild a healthy relationship with food and their bodies. So, also, according to Balasundaram and Santhanam, nursing care and education are key factors in promoting recovery and improving the overall quality of life for patients with eating disorders. So now let's talk about the main types of eating disorders. So first we have is anorexia nervosa. So this is a condition that is characterized by an intense fear of gaining weight and a distorted body image. So people with anorexia often see themselves as overweight, and even when they are dangerously underweight already. So the second type is bulimia nervosa. So individuals with bulimia go through cycles of binge eating, such as consuming large amounts of food in a short period, and then followed by behaviors like vomiting, excessive exercise, or fasting to prevent weight gain. And the third type is binge eating disorder. So this involves repeated episodes of eating large quantities of food. So it is often quickly and to the point of discomfort, but unlike bulimia, it is not followed by purging. So people with this disorder often feel lack of control during the episodes and experience guilt or shame afterward. So now let's take a look at the historical background of eating disorders. So it all began in 1873 when Sir William Gull first described anorexia nervosa as a nervous disease that mostly affected young women. So this marked the earliest medical recognition of eating disorders. Then during 1970s, bulimia nervosa was officially recognized as a distinct disorder that shows that issues related to eating and body image were more complex than previously thought. And later in 2013, binge eating disorder was formally added to the DSM-5, giving it to the same clinical recognition as anorexia and bulimia. Then, after the World War II, media and cultural influences began to promote thinness as the ideal standard of beauty, which greatly contributed to the rise of body image issues and eating disorders. And lastly, in the 21st century, our understanding has evolved already. So instead of focusing on only on psychological explanations, experts now view eating disorders through a biopsychosocial model, meaning that they are influenced already by the biological, psychological, and social factors. So now let's take a look at the prevalence and incidence of eating disorders around the world. So globally, among children and adolescents, the estimated rates range widely from 1% to as high as 22%, depending on the study. So the most common types among children are pica, affecting about 2.1%, and binge eating disorder at around 1%. So for adults, the lifetime prevalence varies by type. So we have the anorexia nervosa, which affects about 0.9 to 4% of the population, and second one is the bulimia nervosa, which affects around 1 to 2%. And then lastly, the binge eating disorder is which is the most common, ranging from 2% to 3.5%. 3.4%. So during the COVID-19 pandemic, there was a dramatic increase in eating disorder cases. So youth medical visits related to these conditions rose by 93% between 2020 and 2023. So now let's move on to the typical age of onset for eating disorders. So for anorexia nervosa, it usually begins between the ages of 14 to 18 years old, which means it often develops during the teenage years or the early adulthood. So this is a stage when body image concerns and social pressure starts to intensify already. So next is we have the bulimia nervosa. So it commonly appears in late adolescence to early adulthood, so around 15 to 24 years old. So people at this age may start experiencing stress or self-image issues that contribute to unhealthy eating behaviors. And lastly, the binge eating disorder often starts in early adulthood, typically from the late teens to the mid 20s. So this may develop as a response to emotional distress, low self-esteem, or difficulty managing emotions. So now let's talk about the progression patterns of these eating disorders. So for anorexia nervosa, the course of the illness is often chronic and progressive. So it means that it can last for many years and gradually worsen if not properly treated. So without early intervention, it can lead to severe physical and psychological complications. So in bulimia nervosa, on the other hand, the pattern is also chronic, but it ends to fluctuate. So meaning that the symptoms may come and go over time. So some individuals experience periods of improvement followed by relapses, especially during times of stress or emotional difficulty. Lastly, the binge eating disorder. It is usually chronic and recurrent, but it generally has a better prognosis compared to anorexia and bulimia. So, with proper therapy and support, many patients can achieve recovery and regain control of over their eating habits. So now let's talk about the theoretical perspectives or the etiologic factors of anorexia nervosa. So first we have the genetic factors. So studies shows that anorexia nervosa has a higher risk for among identical twins, and it often runs in families with a history of mood disorders or substance abuse. Next is the neuroendocrine factors. So there is an evidence of hypothalamic dysfunction, which affects the regulation of hunger and hormones. So amenorrhea, or the absence of menstruation, may occur even before significant weight loss, showing how early hormonal changes can appear. And lastly, we have the neurochemical factors. So people with anorexia may have increased natural opioids in the brain, which can suppress hunger and reduce the desire to eat. So still in anorexia nervosa, the from a psychodynamic perspective, the food restriction is seen as a way for individuals to gain a sense of control. So especially when they feel powerless in other areas of their life. So controlling their food intake gives them a feeling of mastery and stability. And in the cognitive behavioral view, the problem often starts with a distorted body image and perfectionism. So the person may see themselves as overweight even when they are dangerously thin or underweight already. So and then from a family perspective, stress, conflict, or high expectations at home can also trigger or worsen the disorder. And lastly, on a societal level, the media's promotion of the thin ideal plays a major role. So, constant exposure to unrealistic beauty standards can cause individuals, especially young people, to associate thinness with worth, success, or attractiveness. So now let's talk about the etiologic factors of bulimia nervosa. So um, bulimia nervosa often runs in families and is also linked to imbalances in serotonin and norepinephrine. So which these are the brain chemicals that regulate the mood and the appetite. So because of this, the patients with bulimia often respond well to antidepressant medications such as SSRIs. And next, for the psychological factors, bulimia often begins with restrictive dieting, so which it eventually leads to binge eating due to feelings of deprivation. So after binging, individuals experience guilt and shame, leading them to purge through vomiting, fasting, or excessive exercises. And then lastly is the social cultural factors. So family conflict, criticisms, or high expectations can increase the risk of bulimia. So in addition, media influence and peer pressure play a major role by promoting thinness as the standard of beauty, which fuels dissatisfaction and distorted eating behaviors. So now we have the binge eating disorder. So binge eating disorder often runs also in the families and is linked with obesity and mood disorders such as depression. So study also show that people with this condition may have overactive brain reward centers, making them more sensitive to the pleasurable effects of food. So sometimes referred to as a form of food addiction. So next are the psychological factors. So binge eating can also be triggered by stress, sadness, and loneliness. So people may use food as a way to cope with emotional pain or feelings of emptiness. However, after binging, guilt and shame often follow, which can worsen the cycle and make it hard to stop. And lastly, we have the social cultural factors. So in today's environment, we are surrounded by easy access to calorie dense foods, while media pressure and weight stigma can increase body dissatisfaction. So these can actually influence the or reinforce binging behaviors and make recovery more challenging for people with this type of disorder. So now we have the nursing process. So for the assessment, of course, we have to assess the nutritional status of our patient, their weight changes, BMI, and eating patterns, and then we also have to do physical assessment. So this includes our vital signs and to check their hydration, their electrolytes, their skin, or hair, and then their dental health also. And then for the psychological state, we have to ask them regarding to their body image, self-esteem, mood, and control over eating. And for the behavioral patterns, if they exercise regularly, or about their impulsivity and their coping strategies. And then also for the social or family, so about their relationships and supports, and any if they have any conflicts that they are experiencing right now. And then for the safety concerns, if the patient is experiencing arrhythmias, dehydration, metabolic issues, or any thoughts of self-harm. Okay, so of course, our goals of care. So, as nurses, we have to help the patient establish a nutritional eating pattern, and we also have to help the client identify emotions and develop non food related coping strategies. And we also have to help the client deal with body image issues, and we have to provide client and family education. So, in our care, we don't only focus solely in our clients, but we also have to include the family, especially in giving health teaching or education. Okay, for our nursing diagnosis, so these are some that we've identified related to these disorders. So for anorexia nervosa, imbalanced nutrition, less than body requirements related to self-imposed starvation and food restriction. Second one is ineffective individual coping related to maladaptive focus on weight control and difficulty managing stress. And for bulimia nervosa, these are the nursing diagnosis. So first one is deficient fluid volume or fluid volume deficit related to self-induced vomiting and misuse of laxatives. Second one is ineffective individual coping related to use of maladaptive behaviors to manage stress. And for the last disorder, binging eating disorder, these are the diagnoses. So imbalanced nutrition, more than body requirements related to recurrent episodes of excessive food intake without compensatory behaviors. And lastly, low self-esteem related to negative self-perception associated with binge eating. And now we have our concept map that will be presented by my other group mates.
Okay, thank you, Erin, for that wonderful overview of what our topics are for that we will be presenting for today. So, for my part, I will be explaining the anorexia nervosa. So first is we will tackle or dive into of the factors on why it happened. So first is we'll be tackling the biological influences. So first is we have the genetic influence. So with the genetic influence, certain genes influences the temperament and brain chemistry like the serotonin, dopamine pathways. So traits like rigidity, high consciousness, harm avoidance, perfectionism, and anxiety run in the family. So this leads to inherited personality affected traits. So those temperament traits shape how the person reacts to stress and body image pressures, leading to perfectionism and anxiety, make someone more likely to focus on one's appearance and set extreme rules. For example, the client says, "I must be thin." So next it is once a person inherited the traits, so this leads to susceptibility to distorted body image and weight concerns. So perfectionistic or self-critical cognitive styles has biases, attention to perceived flaws, and increase the sensitivity to cultural message about thinness. So mood dysregulation like depression or anxiety can magnify negative self-evaluation. So this leads to the cognitive distortion. So the client may say that I'm fat, so despite the low weight. And high value places on control or achievement make restrictive dieting an appealing strategy. So it gives a measurable way to pursue perfection. So the susceptibility to body concerns leads to adoption of restrictive eating as control or coping. So the person or the individual adapts dieting, fasting, and excess exercise. So this reduces the anxiety about the body shape and image and to achieve a sense of mastery. So restriction is emotionally reinforcing. So the success of weight loss temporarily reduces anxiety and boosts their self-worth. So because of restriction is a reward, so this reduces anxiety and perceived control. So it's repeated and intensified. So they narrow the rules. So they count the calories, they skip the meals, and social eating is avoided. So leading to their eating declines. So with the restrictive behavior, it leads to progressive food avoidance, leading to starvation. So ongoing caloric deficits, it depletes the glycogen in fat stores. The body shifts to catabolism of the muscles and organ protein, so the weight falls. So behavior like repeated restriction of eating is a proximal cause of inadequate intake. So over time, this produces the physiologic state called starvation. So malnutrition, metabolic adaptation, and organ dysfunction. So next is the neuroendocrine abnormalities. So the hypothalamic dysfunction leading to the disrupted hunger, satiety, or fullness, and reproductive hormones. So the hypothalamus integrates signals like leptin, ghrelin, insulin, and the CCK to regulate appetite and also controls the GnRH secretion that drives the menstrual cycle. So dysfunction or altered set point from stress or genetics can change the hunger perception and the reproductive hormone release. So when the hypothalamic signaling is abnormal, normal cues to eat may be blunted, and reproductive hormones fall, producing amenorrhea even before large weight loss in also some cases. So with disrupted hormones, it leads to amenorrhea or the loss of the menses. So reduced GnRH lowers the LH in the follicle stimulating hormone, leading to low estrogen and the absence of the menstruation. So amenorrhea can be misinterpreted by the client as proof that weight is still present or as something not connected to undernutrition. And the hormonal changes may blunt hunger, so both effects reduces motivation to eat. For someone losing menses becomes a dangerous or it's a proof that dieting is working, and it reinforces the restriction of eating. Now with amenorrhea and blunted hunger, it our drive or the drive to eat decreases and their cognitive distortions increases. So the physiologic appetite signals are weaker, so the cognitive distortions like I'm still fat or I don't need food are less challenged by hunger sensations. So with less internal drive to eat and strong cognitive reasons to avoid eating, restrictive behaviors are easier to maintain and intensify. So persistent restrictions leads to starvation. So ongoing mismatched energy intake. So this leads to chronic negative energy balance. So the loss of lean body mass, metabolic adaptation. So the neuroendocrine changes both permit and help perpetuate the behaviors that physically produce starvation. So lastly, from in the biological influences, we have neurochemical influences. So the endogenous opioids leads to blunted hunger and pain signals as a reward from fasting. So fasting and stress increases the release of endogenous opioids like beta endorphin. In some people, opioids reduce nociception and can produce mild euphoria and anxiolysis. So opioids can also interact in appetite and reward circuits. So because fasting itself elevates opioids, starving becomes self-reinforcing. So it reduces the emotional pain and can feel rewarding, and opioid effects can reduce perceived hunger. So with blunted hunger and reward, there is the denial of appetite. So the physiological hunger cues are less intense. So the subjective sensation, like the client stating that I'm not hungry, replaces the biological drive. So the individual experiences less discomfort from not eating. So with that, um, if hunger isn't compelling and restrictions feel rewarding, it's easier to continue avoiding food. So after that is denial and reward. So it leads to positive reinforcement of restrictive behaviors. So each successful period of restriction produces opioid-mediated relief or reward. So there's less anxiety, a sense of control, learning or reinforcement mechanisms like dopamine and opioid interplay strengthen the behavior. So with reinforced habits became persistent patterns. So the person increasingly relies on restriction as their coping strategy. So with reinforced restrictions, there's an ongoing avoidance of eating. This leads to starvation. So long-term repeated restriction, uh, uh, cu- cumulative to caloric deficits, physiologic adaptation, and malnutrition. So the maintained behavior like avoiding avoidance of eating is a direct cause of starvation. So with that out of the way, so we'll be moving on to our psychological factors. So first is the psychodynamic. So with unresolved separation or individualization conflict. So from early childhood, the individual may have difficulty establishing autonomy or independence from their caregivers. So often an over controlling or overprotective parent. So the person's self identity becomes fragile and they may feel powerless in asserting independence. So with this, it leads to food restriction as a means of control. So the individual discovers that controlling food is one of the areas that they can exert total control. So sometimes they lack um, in emotional relationships. So refusing to eat becomes a symbol of independence. So this leads to starvation. So over time, the act of restriction becomes the habitual and reinforces feelings of autonomy and mastery. So even as it leads to malnutrition and physical deterioration. So the individual equates thinness and strength and self-control. So deepening the starvation pattern. So the second part is the cognitive behavioral. So the person becomes a perfectionist and has distorted body image. So the person sets unrealistic high standards for themselves and constantly feels inadequate. So they misperceive their body as being fat, despite being underweight. So this leads to perceiving self as overweight. So this distorted body image triggers anxiety and self-criticism. So weight and shape becomes central to self-worth, leading to restriction or exercise to fix their flaws. So the person begins dieting or exercising excessively to achieve perceived perfection. So initial weight loss temporarily reduces anxiety, creating a powerful negative reinforcement cycle. Leading to restriction lowers anxiety and habit formation. Okay, so with this, the short-term relief reinforces the behavior. Each instance of restricting food reduces the stress and provides a sense of control. So this gradually conditions the mind to associate restrictions with calmness and self-worth, leading to starvation. So as a restriction becomes habitual, so nutrition deficits worsen, appetite signals weaken, and also obsession or control intensifies, so leading to persistent self-starvation. And lastly, our last factor is the social cultural. So first under this is the family influence. So high parental expectations, perfectionism, or family stress. So families that emphasize achievement, success, or appearance can make the child feel pressured to meet the ideal standards. So conflict avoidant or enmeshed family dynamics may limit emotional independence. So there's an increase of the child's need for achievement and control. So the child or the individual internalizes that the belief that worth depends on the performance and external approval of people. So when they can't control family stress or meet expectations, they redirect control towards their body, leading to the lack of autonomy, leading to body or food control. So food becomes a controllable domain, a symbolic expression of independence and success. So the individual uses restriction to manage feelings of inadequacy and helplessness, leading to starvation. So continued restrictions provides a false sense of mastery amid family tension, leading to entrenched starvation patterns. So next is the societal pressure. So thin ideal internalization. So from social media and also cultural standards. So they glorify the thinness and the beauty standards. So they perceive this as beauty and success. So individuals internalize this ideal and equate thinness with their self-worth. This leads to social comparison. So they begin comparing themselves to celebrities, peers, and influencers. So there's a discrepancy between the real body, and their idealized image or body causes dissatisfaction of one's own body. So this leads to body dissatisfaction, leading to dieting behavior. So dieting or excessive exercise begins as an attempt to reduce the gap between actual and their ideal body image. So early compliments or attention serves as positive reinforcements. For example, they they get a compliment, so they perceive this as a good a good step, or it's a good compliment, or to themselves they feel they should pursue more to get their ideal body. So next is the positive reinforcement from peers and society, leading to escalated restriction. So praise from their peers for their weight loss boosts their self-esteem and ego and validates their behavior. So the fear of weight gain strengthens the obsession with control and thinness, leading to starvation. So restriction becomes compulsive and eating becomes associated with guilt, leading to sustained self-elevation. So so we will be moving on how starvation uh, leads to all of these clinical manifestations. So first is we have protein and calorie deficiency. So with the decrease of subcutaneous fat, so prolonged caloric deficits in the body to mobilize stored triglycerides from adipose tissue for energy, leading to subcutaneous tissue or the fat shrinking. So the subcutaneous fat insulates the body and reduces heat when fat is lost. So insulation decreases, so the body loses the heat more readily, and the core temperature tends to fail. So this leads to the impaired thermoregulation. So as the body attempts to reduce the heat by increasing peripheral insulation, so in us humans, uh, our body produces these fine hairs called lanugo, a physiological response to help trap the thin layer of air and reduces the heat loss. So next is the impaired liver process of carotene. So with malnutrition, the liver's normal metabolic capacity is reduced, so enzymes transport and conversion of dietary um, caroteroids, example beta carotenes, to vitamin A is impaired also. A very high intake of carotene-rich vegetables during restricted diets can exceed processing capacity. So this leads to keratin accumulating. So if the conversion or clearance is reduced, but intake or redistribution continues, keratin builds up in the circulation and is deposited in adipose, the tissue and skin. This leads to having yellow skin. So keratin is a yellow orange pigment when deposited in the stratum corneum, especially in the palms and soles. It produces a visible yellowish discoloration called hypercarotinemia. So with this, we have the low albumin, so low protein. So protein deficiency lowers production of plasma proteins, um, and then it decreases the oncotic pressure. So albumin is the major contributor to the plasma oncotic pressure that holds the fluid inside the blood vessels. So when albumin falls, the intravascular oncotic pressure drops. So this leads in the fluid shift. With a lower oncotic pressure, the balance between the hydrostatic pressure pushing the fluid out and the oncotic pressure pulling the fluid in is altered. So no net movement favors the liquid leaving the capillaries into the interstitial spaces, leading to edema. So when gravity and dependent areas collect the excess fluid, the interstitial fluid are producing visible swelling of the limbs, leading to peripheral edema. So after that is we have the decrease of vitamin C and K. So leading so this inadequate intake causes low levels of vitamin C, so needed for hydrolysation of uh, proline and lysine and collagen synthesis, and vitamin K. So it is necessary for clotting factors. So with decrease of collagen synthesis makes the vessels fragile. So collagen is a structural protein in the vessel walls. So with a poor collagen production, it weakens the vessel's integrity and the capillary support. So with the decrease of clotting, increases the bleeding tendency. So without the function of vitamin K, dependent clotting factors, the coagulation cascade is impaired. So small vessel injuries bleed more easily. So this produces petechiae or ecchymosis. So fragile capillaries plus reduced blood clotting, leading to minor ruptures. So it produces a pinpoint of hemorrhages, so petechiae, and larger bruises like ecchymosis. So next is when there's low body fat, this leads to thyroid activity. So it reduces the heat production and hypothermia. So with less body fat, the loss of adipose tissue reduces leptin and caloric stores. So with the decrease of thyroid activity and starvation, peripheral conversions of the T4 to the T3 is decreased. So this is an adaptive response, and the overall thyroid metabolic drive is suppressed to conserve the energy. So low leptin also signals the energy scarcity to the hypothalamus and also the pituitary, and also it decreases the thyroid axis activity. So with this, it reduces the heat production. So thyroid hormones, especially the T3, increases the basal metabolic rate and the thermogenesis. So lower thyroid activity reduces cellular metabolic heat production. This causes hypothermia. So with less metabolic heat generation, the less insulation from fat loss. So the core temperature drops and the patient or the client becomes hypothermic. So with this, a low body fat leading to low leptin. So with this, so adipocytes produce leptin proportional to fat stores. With fat loss, leptin falls. So with this, the hypothalamus senses low energy availability via leptin and the other signals and downregulates the reproductive function as an energy saving adaptation, reducing the pulsatile GnRH release. So there's low GnRH lowers the LH and FSH. So the GnRH stimulates the pituitary gonadotropes to secrete the LH and FSH. With less GnRH, the LH and FSH secretion falls. So with low LH and FSH or the follicle stimulating hormone, there's low estrogen. So the ovary stimulation decreases. So estrogen and progesterone production falls. So there's decreased menstrual cycle stops. So low estrogen disrupts the endometrial cycle and the ovulatory function. So menstrual periods stop and are delayed. So this leads to amenorrhea. So next is when there's low body fat, there's slow GI motility. So starvation causes decreased interactivity. So the gut motility slows due to the production caloric load, to altered autonomic tone and hormonal changes. So this leads to the thyroid hormones to become low. So as above, starvation um, produces peripheral thyroid activity. Okay, next is we have when the body fat decreases. So we have the slow GI motility. So what happens is that starvation causes decreased enteric activity. So the gut motility slows due to the reduced caloric load. So altered autonomic tone and the hormonal changes. So this leads to tired hormones decreases. So starvation reduces peripheral thyroid activity and circulating T3 and T4. So with this, the low decrease of thyroid and also with the decrease of fat causes cold intolerance. So lower thyroid levels mean less thermogenesis. So low of fat reduces the insulation together. These increases the sensitivity to cold. So clients may be feeling they may feel chilled and intolerant of lower temperatures. So they may feel that their surroundings cold. So with this, we have the slow GI motility. So with the decrease of thyroid hormones, then there's low fat insulation. So energy intake insufficient, blood glucose drops intermittently, so glycogen stores deplete, then hypoglycemia and reduce of substrate of tissues. So with reduced thyroid hormones and low glucose availability, lower the CNS and the muscle activity. So this causing fatigue and lethargy, or the patient may be, or the client may be lethargic. So to conserve energy under caloric scarcity, so the sympathetic drive decreases the intrinsic cardiac pacemaker activity, reduces the autonomic system, shifts to the lower metabolic demand, so leading to bradycardia. Also, the loss of cardio muscle mass contributes. So, um, so bradycardia is adaptive, but it is also risky. So the slowed heart rate reduces oxygen and ATP demand, but extreme bradycardia can impair the perfusion and also predisposes the client to having an arrhythmia. So with slow GI motility and prolonged calorie restrictions, this leads to loss of fat muscles and emaciation and significant weight loss. So what happens is when the body continuously catabolizes adipose and then muscle protein to provide substrates for glucogenesis and energy, the GI motility slows because intake is low and enteric stimulation is reduced. So loss of fat and muscle causes emaciation. So progressive tissue wasting gives a visibility thin, gaunt, and appearance with muscle wasting. So leading to significant weight loss. So you can see that the person is way above his or her weight and emaciation. So um, with this starvation and purging behaviors, so it leads to oral and facial changes. So chronic and self-induced vomiting leads to repeated stimulation of the salivary glands and parotid gland hypertrophy. So frequent vomiting repeatedly activates the salivary secretions and the mechanical stimulation of the salivary glands. So the recurrent glandular activity causes hypertrophy or the enlargement, and sometimes um, the non-inflammatory swelling. So this leads to the parotid hypertrophy. So overstimulation or the continuous or the chronic overstimulation and autonomic changes lead to the gland enlargement. Sometimes inflammation or fatty infiltration contributes to persistent swelling. So with self-induced vomiting and repeated exposure of teeth to acid, leading to dental enamel erosion. So the stomach contents contain hydrochloric acid. This is a um, low pH. So when the vomitus or the vomit repeatedly contacts with the teeth, the acid demineralizes the dental enamel. So with that, enamel is mineralized but susceptible to acid dissolution. So repeated acid exposure softens the strips of the enamel, leading to sensitivity, leading to translucent and increase um, um, the risk of destroying one's teeth. So next is with self-inducing vomit, mechanical trauma from fingers or objects on the teeth. This leads to Russell signs, so scars like calluses and dorsal hand knuckles. So people who are induced in vomiting places their hands or their fingers in their mouth. So or they may place objects in their mouth. So into their posterior oropharynx. So the dorsal surfaces of the hands are repeatedly strike the teeth. So with repeated friction and the microtrauma of the knuckle or skin over the metacarpophalangeal joints, this causes the scarring of the hand, callus formation, and the hyperkeratosis, which is visible in the Russell sign. So with that out of the way, we will be moving on to the diagnostic criteria, the DSM-5. So with the DSM-5 for anorexia nervosa, so we have criterion A. So I will just summarize everything because everything can be read in the PowerPoint. So I'll be summarizing what this diagnostic criteria is about. So as you can see, criteria A, so it is the restriction of energy intake. So the individual eats far less than needed, leading to a significant low body weight for age, sex, and health. For criterion B, intense fear of weight gain. So despite being underweight, there's an intense fear of gaining weight or persistent behaviors that prevent weight gain. For example, food restriction, excessive exercise, and vomiting. And lastly, for criterion C, there is distorted body image. So the person has a distorted perception or on how they see their body. So they overvalue thinness and they deny the seriousness of having low weight. So after that is detecting the remission specifiers. So we have two. So there's partial remission. So the weight has returned to normal, but fear of gaining weight of body, the fear of gaining weight or body image disturbance still remains. So the second is the full remission. So none of the diagnostic criteria have been met or for a sustained period. Okay, so next is the severity levels. So based on the BMI, so we have mild, so the BMI is less greater than or equal than 17 kg. Moderate is a BMI of 16 to 16.99, and the severity of we have we have 15 to 15.99, and extreme the BMI is less than 15 kg. So with that out of the way, so we will be moving on to our nursing management. So we will be tackling the independent nursing interventions. So our first nursing interventions is assess eating patterns, weight history, fluid intake, and elimination, and also exercise. So this establishes a baseline for nutritional intake and activity level. So also this helps the identity restrictive behaviors, compensatory methods like purging, excessive exercise, and also dehydration. So it also aids in like tracking the progress of the individual during their recovery process. So with that, next is the reassess the weight, the vital signs, the hydration status, and skin mucous membranes daily. So as we frequently monitor, they detect the physiological effects of starvation. For example, while we take vital signs, the blood pressure, they may be hypotensive. For the pulse, they may have bradycardia, and also when checking their mucous membrane, they may be dehydrated. So skin and mucous membranes reflect hydration and also the nutritional status of the client. So daily weights help evaluate the progress, uh, the progress safely. So like if nag-gain ba sila of weight, or if not, there's no sudden fluid retention. So the third is we have monitored the client during and after meals to prevent food avoidance or purging behaviors. So we ensure that the food is actually consumed and it's not hidden or kept hidden by the client, or maybe it could be thrown by the patient or discarded to be purged later. So supervision after meals, so especially for 30 to 60 minutes, it helps preventing the client from vomiting. So next is we encourage journaling of food intake, thoughts, and emotions. So journaling promotes the being self-aware of the triggers and emotional connections with eating. So it helps identify the cognitive distortions and allows us nurses and also the therapists to track the progress in the therapy. And lastly, for the independent is we have to promote the expression of feelings about their body image and also one's self-worth. So we provide a therapeutic outlet for guilt, shame, and also distorted body images. So encouraging verbalization, so it builds trust and it supports the emotional healing by replacing like punishment to oneself with and communication. So with that, so we have dependent nursing interventions. So with that, first is we have administer prescribed SSRIs like fluoxetine or atypical antipsychotic like olanzapines. So SSRIs will help reduce obsessive thoughts and anxiety around food, and olanzapine may help increase appetite. It reduces distorted thinking and stabilizes the mood. These support psychotherapeutic progress. Second is we assist in NGT or the nasogastric uh, insertion or parenteral nutrition if prescribed. So used when oral intake is severely restricted or unsafe. It ensures controlled, gradual nutritional rehabilitation while preventing refeeding, while preventing refeeding. So next is we implement weight restoration plan and gradual caloric increase as ordered. So gradual refeeding prevents circulatory overload and also metabolic imbalances. For example, phosphalemia. I'm sorry. So it reestablishes normal metabolism and restores body tissue safely. And we'll be moving on to the collaborative interventions. So we work with the dietitians to create a structured meal plan for our client. to provide balanced nutrition tailored to the client's needs and tolerance. So a structured plan reduces anxiety by removing uncertainty about what or how much they would eat. And we should refer to a psychotherapist, yeah, or a refer them to a psychotherapy, I'm sorry, like the cognitive behavioral therapy, family-based therapy, or group therapy. So CBT addresses the distorted thoughts, family therapy improves the communication and reduces control conflicts. And also group therapy builds peer support and accountability. So the third is we coordinate with social workers for family support and community resources. So we we connect patients and family to their ongoing care. So financial help and support groups ensure continuity of recovery after discharge. So lastly is I'll be tackling so second to the last is I'll be tackling the medical management. So first is the gradual weight restoration program, so nutritional rehabilitation. So it reverses the malnutrition, rebuilds body stores, and also normalizes metabolic function. So a gradual approach avoids the strain on their heart, which is as explained earlier in our concept map, the person may um, experience a bradycardia and also will have electrolyte imbalances. Second is the nasogastric tube or the NGT or parenteral feeding when oral intake is insufficient. So used when the client refuses to eat or they cannot meet their caloric needs. So provides essential nutrients and directly prevents further weight loss or organ damage. So the third is prescribed medications like the as stated earlier, the SSRIs, atypical antipsychotics, and anxiolytics. So targets comorbid depression, anxiety, and obsessive behaviors that sustain anorexia, and promotes mental stabilization for therapy participation. Four is correction of the electrolyte imbalances, potassium, magnesium, and phosphate. Okay, so this prevents the cardiac arrhythmias, muscle weakness, and also refeeding syndrome. So common life-threatening complications during the renourishment of our client. So lastly is we have the hormonal or endocrine monitoring and treatment. So assess the effects of the starvation or yeah, assess the effects of starvation on thyroid, cortisol, and reproductive hormones. So addresses the amenorrhea and metabolic suppression caused by malnutrition. So lastly, for anorexia nervosa, these are the expected outcomes. So demonstrates progressive weight gain towards individualized goals. So it indicates that effective nutritional rehabilitation and improve metabolic function. So second is consume prescribed meals and snacks without refusal or withdrawals. So it shows that reduce anxiety about eating and improve self-control. Third is the vital signs and labs will remain within normal range. So it reflects that the client is recovering and also homeostasis is being achieved and the correction of malnutrition related abnormalities. Fourth is they verbalize reduced anxiety related to the food and also their body image. So it suggests that um, improvement um, in cognitive distortions and emotional coping. And fifth is they participate actively in therapy sessions. So it shows that engagement and motivation is necessary in the recovery process. And lastly, identifies positive coping strategies and yeah, identifies positive coping strategies other than food restriction. So demonstrates the acquisition of adaptive skills for stress and emotional regulation. So that is all for anorexia nervosa. So we will be moving on to our next disorder.
Thank you, Wayne, for explaining to us what is anorexia nervosa. So now we will proceed to the second common eating disorder, which I will be talking about, which is called bulimia nervosa. So compared to anorexia nervosa, bulimia nervosa is the exact opposite. It's still another eating disorder, but instead of avoiding not eating, it's the opposite. It's more of like the person is eating more than they're supposed to be eating, in contrast to anorexia nervosa. So moving on, we already know what it's about. So let's briefly go through the predisposing factors. Okay, so first is we'll talk about the biological factors or the biological influence. So here, uh, so, for the biological factors, first of all, bulimia nervosa is not purely hereditary, but genetics can increase vulnerability. So, a person who has a relative with an eating disorder may have a higher risk, especially if they also have serotonin or norepinephrine imbalance. So, yeah, having anybody in your family that could have bulimia nervosa disorder does increase the risk of having this kind of disorder. Okay? You get influenced. If the person has any inherited serotonin or norepinephrine dysregulation, this can affect in their mood, their impulse control, and their appetite regulation, which makes the person more prone to binge purging behavior. So you're probably thinking, what is binge purge behavior? We'll talk about that later. But
let's move on now. That's it for the biological factors. Let's move on now to the psychological factors. Now, the main theory here based here is the cognitive behavioral theory. So, according to this theory, strict dieting leads to loss of control. So, this basically means the person tries to control their diet, but instead of disciplining themselves, their body will feel like they're more deprived of the feeling of eating. Like, okay, today I'm only going to eat 2 meals a day. But by doing that, by conditioning yourself that you only have 2 meals a day, you'll feel like, oh, I'm not eating enough. So therefore, you're gonna end up having a bigger urge to eat, and that urge becomes stronger. So eventually, with this strict dieting, the urge becomes stronger. Therefore, this eventually manifests in the person to feeling negative emotions such as guilt, shame, or anxiety, which can trigger binge eating as a way to cope. So eventually, after eating, guilt increases, leading to purging, which basically means to help relieve anxiety. Okay, so purging, let's remember that it means to cleanse. Okay, it just means to cleanse. And so binge purge eating, this forms basically into a maladaptive binge purge cycle. So this is marked by uncontrolled episodes of overeating, such called as binge eating. So those are the psychological influences. Now let's move on to social cultural. So there's our body, there's our mind. Now let's talk about the outside factors, our environmental factors. So here, family stress, peer pressure, and media pressure, they're all basically outside factors which basically influence the individual to they expose them to the thin ideal, like the idea that, oh, we probably should be having like the thin body is the ideal type of body, when in fact it's really not. Like every body type is unique in its own way. That just because you're thin or you could be overweight does not dictate your um like your status or like the beauty ideal. So yeah, there's the thin ideal, and there's also family criticism. Kana yung family, whenever they would point out, oh, you're getting thin, you're getting fat, it does have a big influence in an individual. So you really should think about that. It's pretty common in the Philippine household to have that kind of influence. So yeah, family criticism or pressure to achieve can increase body dissatisfaction. So with the amount of pressure building onto you, the amount of judgment and criticisms, this eventually lets a person feel more conscious about themselves as they become more anxious. So this basically builds up a weight stigma. So as you can see there, a weight stigma of the internalized thin ideal. So basically it makes the individual believe that their self-worth depends on the body shape and weight. And as I've said, that shouldn't really matter because everybody is unique and different in its own way. But that's how we should understand. That's in the case of an individual with bulimia nervosa, they think otherwise. So those are the factors. So going down, this with all those three factors together in the way, this eventually all allows a person to feel emotional distress and body dissatisfaction. So they become more stressed about themselves, they become more anxious, and they become more stressed about their own body. Okay, going down, okay, go down the the concept map, Lawrence. Okay. So with all those factors, it eventually again, the individual starts to feel more emotional distress and body dissatisfaction. So with a person with this disorder, they start to, their way of coping is by eating. So this eventually starts to manifest into binge eating episodes. So what exactly is binge eating? So binge eating involves consuming a large amount of food within 2 hours with loss of control. Like, of course we eat, it makes us feel better, but having to eat so much within 2 hours, that's already that's a lot. Our bodies can only handle so much. So that's the problem that's starting to trigger right from there. So from binge eating episodes, eventually large this basically involves a large food intake. That's what binge means. And there's loss of control in life, and that's how the person starts to seek comfort with food. So yeah, so remember what I said about purging. So the binge purge. So purging basically means, again, it's to cleanse. So by purging temporarily, it relieves the guilt and anxiety. So through eating so much, it gives temporary relief. So because it activates the brain's reward pathway, which is dopamine. But however, this relief is short term. That's why it's very temporary. And eventually, after the individual finishes eating, they return back to feeling the negative emotions such as shame and guilt. So that's after the binge. So because they feel that their self-worth is tied to their body image, they eventually feel the strong urge to undo the calories that they consume. Like, oh, they've eaten so much, but eventually they start to realize, like, oh my God, I did eat too much. And the idealized, coming back into the factor now, they've already idealized that the thin ideal body is the ideal body. They feel like, oh my God, I went too far. So they want to undo it. So eventually, this is basically the beginning of them feeling their fear of weight gain. So this basically restarts. This is where the brain starts to think, oh, eating might be the solution, but then after you eat, they start to feel like, oh my God, you went too far. So with that fear building in, we now move on. The person will eventually lead to are going through compensatory behaviors to compensate for their act of overeating and for the guilt. So let's talk about that. So their compensatory behaviors, you've eaten a lot, right? So there are different ways a person would probably deal with that. So there are naturally the three different ways. But the most common, first of all, is vomiting. Second is taking in laxatives or diuretics, and third is excessive exercise. So let's talk about it individually, but we'll just go through it and explain it carefully. So first of all, vomiting. So after the individual has eaten so much, of course, when you feel like when your stomach's getting too full, you eventually realize like, okay, so since it's full, you have to expel it out. Like if you go let it go out, eventually you'll go back to normal, right? So vomiting. So vomiting involves the person themselves to vomit, or in the mind of a person with bulimia nervosa, they feel like they're getting rid of the extra food. So when you vomit, you're not just expelling food. You have to take note of that, but you're also expelling your stomach acid, and that's important to know because our stomach acid contains potassium and chloride. So when it's lost, this decreases your potassium, this decreases your chloride, and eventually it leads to metabolic alkalosis, guys. I'm pretty sure we're already familiar about this since our med surge. So metabolic alkalosis. So with less stomach acid in our body, our pH also goes down. So our body becomes too alkaline or basic na. So this basically happens when this occurs when the body or the person vomits too much. Okay, so when they vomit too much, it can also eventually lead to dehydration and electrolyte loss. So electrolyte imbalance, so dehydration. And when the body has imbalanced electrolytes and dehydration, this decreases absorption. So this can cause poor absorption and eventually weakness and damage to the GI tract. Next, let's talk about laxatives. So the use of laxatives or diuretics. So laxatives, or just a little recap, laxatives cause a rapid loss of stool, so it makes us poop more, while diuretics cause us to lose lots of water through our urine, so it makes us pee more. So by the in the mind of the person with this disorder, they feel like, okay, if I just instead of like allowing my body to properly absorb these food, I'm going to take this medication to rush it to quickly expel the waste faster, but that shouldn't be the case. So what happens here is that this basically leads, so by taking these medications, you're basically rushing the metabolic processes in your body. So this eventually leads to dehydration and loss of electrolytes. So similar to vomiting, this decreases absorption in the body, and there's GI inflammation and eventually impaired digestion. And this can also, for in this case, this can shift the acid-base balance. But compared to vomiting, this can also sometimes cause metabolic acidosis because vomiting can cause alkalosis, but for taking if you take too much laxatives or diuretics, this can cause acidosis. This is due to fluid loss and poor tissue perfusion. And here it doesn't actually remove the calories. Okay, just because you're peeing and you're pooping faster, it doesn't actually remove all the calories you've taken. No, the only thing that goes out is just the water and the minerals, which is whatever is left there will eventually increase your pH value, and that's why it causes metabolic acidosis in your gut. So that's it. So that's for laxatives and diuretics. Next, we'll move on to excessive exercise. Another way for an individual to compensate for their like guilt of eating too much. Some people will eventually lead to excessive exercise. So, okay, they're not going to vomit it out. They probably wouldn't like taking medications either. So maybe if they exercise faster and sweat faster, they'll probably be able to lose the extra calories, lose the weight by sweating it out. Well, let's figure that out. So let's take note that excessive exercise can cause physical strain. When a person is suffering from bulimia nervosa, note that they're not when they exercise, they're not doing it for fitness. No, they're thinking of burning off the calories because of the guilt that they feel. Like, okay, I feel bad, so since I eat too much, I'm going to exercise to let it all out. So with that still ongoing pressure in their minds, this causes physical strain and leading to increased energy expenditure. So so they're using a lot of energy in their body, therefore still using out all those calories that they intake through the food. So when combined with poor nutrition, especially if the foods they're not eating is not healthy, it can even too much exercise can worsen their fatigue, increase electrolyte loss through their sweat. Okay, mind that, and it can also increase cardiac stress. So with those three compensatory behaviors, this eventually leads to the following: going down, this eventually leads to systemic physiological consequences. So those were just the compensatory behaviors. Let's now understand um, how it will be affecting our body. So what happens to our body whenever the individual goes through these different behaviors? So first of all, when electrolytes stay low, first is chronic electrolyte imbalance. So that's the dehydration. So when electrolytes stay low for a long time, multiple organs are affected. So this involves especially the heart, the muscles, and the brain. So, di ba, every time we vomit, eventually you're also going putting out the acid, your chlorine and your potassium. Potassium, di ba, remember guys, potassium is responsible for our muscle contractility. So with less potassium, this can cause hypokalemia. And with hypokalemia, low levels of potassium, this can eventually cause muscle weakness. And for the case of our heart, this can cause cardiac arrhythmia. And due to if the heart doesn't properly pump pump, this eventually might lead to cardiac arrest, which is already a complication. And other than that, this can also cause physical distress in the body. So that's what you should remember. Next is GI and metabolic impact. So other than the imbalanced electrolytes in your body, there's your metabolic activity in your gut, your gastrointestinal system. So with frequent vomiting and the use of laxatives, this can damage the GI lining, this and thus causing inflammation and impaired digestion. Following examples such as esophagitis, which means the inflammation of your esophagus, because unlike your stomach that has a protective lining, that protective lining against its own acid. By vomiting, you're also exposing you're exposing your esophagus with no protective lining to that very dangerous acid. Our stomach acid is very acidic, and it can really be very, it's really not recommended to always vomit a lot. For a person with this disorder, this is very fatal for them, as this can really irritate their esophagus. Next, there's the parotid gland enlargement. So with that, it can also enlarge our parotid gland, which is here. This with that with the many times the person will keep on vomiting, this can trigger more anxiety and shame. Like, oh my god, they're probably thinking, the person would be thinking, I'm throwing up too much, I should stop, but they wouldn't stop because they feel like this could be a better option rather than just keeping in the food in their body. So with the more shame and anxiety triggered, this eventually leads to the body to struggle to absorb nutrients, therefore worsening their weakness and enhancing their cravings. So this eventually allows them to return back to their compensatory behaviors, and that's why you can see there's always like a cycle coming back again. So that's for the GI metabolic impact. Another impact it does is in the neuroendocrine dysregulation. So this was already mentioned by Wayne. The specific hormones that control our hunger, such as leptin and ghrelin, which become imbalanced. So a person with this disorder, due to the fact they would do the compensatory behaviors, they eventually become imbalanced. So like I said, it will their cravings will eventually grow. Those hormones will keep on shooting, and that's the reason why they feel like, oh, I should probably eat more to cope with whatever distress I'm feeling. So with the increase with due to the imbalance of these hormones, this causes constant cravings and more hunger signals being sent by our brain, and even after eating, this pushes the person back to binging. So that's it. So with that's what happens to our body. With all that being happening in our body, that's how it goes through in our body. Despite all of these, the person eventually still goes back to binging. They still go back to eating. That's why it's called a binge purge cycle. Though this enforces it, because what happens here is that purging basically it provides temporary relief of anxiety or guilt and activates our reward pathway, our dopamine. But remember, guys, it's only temporary. So that's why. So with if you notice someone with that kind of disorder, now it's time. Let's try to understand how this disorder is being diagnosed according to the DSM-5 criteria. So as you can see here, I've bulleted the significant parts, but you can also check the long criteria next to it. But I'll just basically give out the specifics. So basically, in this criteria, when a person has a sign disorder, you're given a questionnaire to answer specific questions. They get interviewed, but these are basically the different criteria to properly diagnose if this person has bulimia nervosa. So first is the binge episode. So recurrent binge eating. So the person has been eating a lot of food. Next they're eating large amount of food in less than 2 hours. Okay, less than 2 hours. That's already considered a lot of food in 2 hours. Like, they would be forced to vomit at that point. And there's also loss of control during eating. So yeah, when you're binging, there's no control. They're not stopping. That's what it is. Next is you check for their compensatory behaviors. So um, the person is already showing their behaviors of either vomiting, they're taking laxatives or diuretics, or they're saying that I've been trying to exercise to get off this weight. That's excessive exercise. So next is frequency. So the frequency according to the DSM-5 criteria shows that people with bulimia nervosa has equal to at least one episode of binge or purge episodes per week within 3 months. So that's like one episode per week, and one episode is equal to less than eating large amounts of food within 2 hours. So if the person eats more than that per week, and it has to be measured within the 3 months. Next is their cognitive feature, which is their self-worth. So in the questionnaire that they're given, they're asked specific questions like, how do you feel, how do you see your body. So they focus more on the client's or the patient's body image of their self. Like, do they really care much about their weight? Like, what's causing them to eat a lot, or the stress. That's why. Then we have exclusion. So exclusion meaning not exclusive to anorexia episodes. So it's important to know that anorexia can also trigger vomiting, because the person would want to feel like, in the case of anorexia, they would want to feel like they're losing weight by vomiting. Meanwhile, I know it's technically it's the same, but basically, this basically means that the binge purge episodes should happen independently, and it's not only during an anorexia phase. Because it's important to remember, there it is. In bulimia nervosa, the person is usually within normal or slightly overweight na ilang body weight. Meanwhile, sa anorexia nervosa, usually the person experiencing that disorder is underweight. For bulimia nervosa, the person can have normal or overweight. That's the thing. But they can still engage in binging and purging regularly. So even if the person has a normal body weight, they can still be diagnosed with this disorder because they could be going through binging episodes of their own regularly. So going to that, all of those, this leads to measuring the severity. So the severity is based on the number of compensatory episodes per week, di ba? The frequency is also measured how many one episode per week for 3 months. So there's the following. First is mild, which shows that there's 1 to 3 episodes per week. Then there's the moderate, which is more than 3, which is 4 to 7 episodes per week. Then severe, which is 8 more than 7, so 8 to 13 episodes per week. And then there's the extreme or the very severe degree, which is more than having binge episodes for more than 14 episodes per week, which is really concerning because we can only take in so much food as we can. So moving on to that, this eventually leads to one of our possible nursing diagnoses, which you can go down. Going down is imbalanced nutrition related to binge purge behavior and inadequate nutrient absorption. So with that nursing diagnosis in mind, let's talk about the appropriate medical and nursing management. So first, let's talk about the medical management. What do the doctors do? What do they prescribe? So first of all, let's talk about the first medical management is pharmacologic therapy, with which the main drug used here are basically SSRIs or antidepressants. A good, very common example for this disorder that you usually prescribe is fluoxetine. This is a SSRI or slash antidepressant that is prescribed to people who have bulimia nervosa and maybe also OCD. Since it's an antidepressant, this medication improves mood and impulse control. So this is basically to help reduce their binge purge frequency, and the mechanism of action here involves increasing serotonin levels in the brain, therefore leading to better emotional regulation to control over their cravings. Next is electrolyte and fluid replacement to correct their hypokalemia and dehydration. So mga atong IV, like IV potassium, sodium, and kanang other IV fluids. Next, we have dental and gastrointestinal evaluation to address the damage. So the doctor will be examining the state of the patient's GI tract, if there could be signs of esophagitis or the enlargement of the glands. So that's what the doctor will do as part to address any damage that's caused by the overeating and the binging. And lastly, we have cardiac monitoring. So, diba, low levels of potassium can cause muscle weakness and also can cause possible cardiac arrhythmia. So that is why the doctors have cardiac monitoring or the ECG to monitor for any risk of arrhythmias or improbable unbalanced beating of the heart. So that's the medical management. So next we talk about the nursing management. So what can we do as nurses to help an individual with bulimia nervosa? So the most common, I'll just go over through it. So the most common, first of all, our independent interventions include monitoring the vital signs, of course, and very would like to highlight the person monitoring their weight, the client's weight, their intake, their output, and whenever you would observe any of their binge purge frequency. So if they're eating a lot of food and what they're supposed to be eating. That's why in the hospital they really take into account how much the patient has eaten, and the food that they always give to them is really specifically made, and the portions are really made for them. Next is basically to provide a non-judgmental environment during meals and to observe post-meal to prevent purging. So as student nurses or nurses in the future, we shouldn't be judgmental. These people who have this kind of disorder they're very anxious. So we really need to provide a calm environment. Like, it's okay for you to feel this way. You don't have to go through everything by just eating. So that's it. Another is to encourage verbalization of emotions and teach the other alternative ways of coping. So, and like such as katungingon ni Wayne, as journaling or breathing exercises. Basically, we have to encourage them that instead of just eating your worries away, you can always just write it down, or you could feel free to vent. You don't have to put your dependency on eating food for your reward or to seek comfort. And then lastly, for the independent is to educate about risks of purging and importance of hydration and structured meals. So it's very important to monitor whenever any client or patient that has this disorder to monitor how much they're eating and any other risk of or hydration, or always try to monitor their meals, how structured it is and how it can be balanced for the good of their health. So that's independent. Next is dependent, of course. Administer the medication such as SSRIs as ordered, electrolyte fluid replacement, and also monitor their lab values and their side effects. So yeah, there's also here mood stabilizers as prescribed, and always monitor for their side effects. So and then now we have collaborative. So of course we have to work with a dietitian for meal planning, and of course in every psychiatric therapy there's always CBT or therapy, and also involve family for support and if ever if ever to prevent any relapse episodes. So lastly, so if once we're able to do that, we're able to properly monitor our patient, we can expect the following outcomes: going down. So the expected outcome show at least the patient should show decreased binge purge episodes, so they're eating less, they're eating more normal than what they should be, not more than what they should. Their electrolytes remain stable, so their ABG results are normal. The patient is able to eat without purging, so they're not able to feel like the guilt of having to cleanse themselves after eating. Then there's also you'd expect after going through therapy, they would have improved self-esteem and having a healthier body image. So at this point, if we do it right, they'd be able to see something more to themselves. And after that, the patient you we would also expect the patient to be able to use positive coping strategies. So instead of eating, they'd be able to show their different ways of coping. And then lastly, the patient should be able to show that they have an active participation in the therapy. So that's when you know that this patient is probably going to recover well though gradual, as long as they're able to actively participate and they're made self-aware. So that's it for my part on bulimia nervosa. Thank you for listening. Now we'll proceed to talking about the final eating disorder, which is binge eating disorder by Florence.
Okay, thank you so much, Gwen. Now that we have tackled anorexia nervosa and bulimia nervosa, let us now move on to binge eating disorder. So, binge eating disorder is characterized by frequent eating and recurrent binge eating episodes with associated negative psychological and social problems, but without compensatory behaviors, which is common to bulimia nervosa. So, according to our DSM tool, binge eating disorder involves consuming more food compared to what is typical in similar excessive circumstances. Now, this disorder is also associated with at least three of the following behaviors, which is eating rapidly, eating until you're uncomfortably full, eating large amounts even when you're not hungry, and eating alone due to embarrassment and feeling disgusted and guilty afterwards. Now, starting off with our biological factor, we have three factors. So this contributes to the development of binge eating disorder. First, we have our genetic. So in our biological, first, genetic predisposition, genetics play a significant role in the development of our binge eating disorder. So individuals who have close relatives, such as your parents or um, your siblings with eating disorders or obesity or linked to depression or anxiety, they are at higher risk for developing binge eating disorder themselves. This indicates that certain genes may influence your brain's mechanism related to your appetite regulation, impulse control, and your mood stability. So, for example, genetic factors can affect how the brain's reward system responds to food, making some people more sensitive to the pleasurable effects of eating. Similarly, variations in genes that regulate your neurotransmitters, such as your serotonin and your dopamine, impact your mood and self control, which increases your vulnerability to emotional or binge eating episodes. Next, we have our low serotonin levels. So, as we all know, our serotonin is a neurotransmitter that helps control our mood, our appetite, and a feeling of fullness after eating. When our serotonin levels are low, your brain has weaker signals, meaning the person does not feel full easily. And you may feel more craving for carbs and sweets, especially sweets, since eating sweets can temporarily raise your serotonin. And the person may experience mood changes as well, like sadness, anxiety, or irritability, which may lead to emotional eating as a form of comfort. Now, next we have hormonal irregularity, specifically your leptin and your ghrelin imbalances. Uh, our leptin and our ghrelin, these are two important hormones that control your hunger and your fullness. So your leptin tells your brain to stop eating when you're full. It's like your I'm full signal. Whereas your ghrelin is the one that tells your brain that you're hungry and that you need to eat something. Now, when these two hormones become imbalanced, the body's hunger signals gets confused, leading to overeating and binging. So if your leptin is low, or if you develop leptin resistance, wherein your brain don't respond to leptin anymore, your brain will not receive the I'm full signal, which results to continuous eating even when they've had enough food. And if your ghrelin levels are high, which is your I'm hungry hormone, uh, your brain constantly feels hungry or craves food, which increases your appetite and frequency of eating episodes. So remember, your leptin is your I'm full signal, and your ghrelin is your I'm hungry signal. And imbalances in these two can lead to overeating and increase in appetite, which raises the frequency of your binge eating episodes. Now, this leads to the person eating more than what is needed, craving a lot, and feels that they have no control when they are eating. Now, moving on to our psychological factors. So, people with low self esteem often feel unworthy, right? Now, that they're unattractive or that they're not good enough. Now, with this, when they also have a poor body image, that they are dissatisfied or ashamed of how they look, these negative thoughts and feelings um, can these thoughts and feelings can lead them to use food for comfort as a coping mechanism, which triggers our binge eating. So when a person feels bad about themselves or their body, they experience sadness and they feel frustrated or ashamed or insecure, and they cope by eating large amounts of food to feel better or to distract themselves from those thoughts. But after but after consuming large amounts of food after binging, they feel even more guilty and ashamed, which further lowers their self esteem. And this tend to becomes a vicious cycle of emotional distress and binge eating. Now, talking about emotional distress, just like what was mentioned earlier, when one feels immensely stressed or anxious, they may turn to food for comfort, which we call emotional eating. And again, these foods, especially sweets, temporarily release what? Serotonin, our feel good hormone, which which would make them feel calm or happy for a short time. But then again, afterwards, they feel guilty or ashamed, which makes their emotional distress worse. And then the cycle just repeats. Next, we have impulsivity or poor self control. So, from the root word impulsive, this means that a person tends to act on sudden urges or emotions without thinking. So, in the context of binge eating disorder, this trait makes it hard for a person to resist cravings or to stop eating once they start. So, for example, when someone with poor self control sees or smells food or feels stressed, they may immediately give in to the urge to eat. Even if they are not hungry at all, they may also have trouble setting limits like, oh, I'll just eat one portion or one cup lang, which leads to rapid and excessive eating. This behavior often gives instant satisfaction or comfort to the person, but only for a short period of time. And then after the binge, the person again feels guilty, regrets it, and self blames. Yet the same pattern repeats, and when another impulse occurs, it then again repeats itself. In some cases, impulsivity is linked to how the brain's reward system works. So people with binge eating disorder may have stronger reward signals when they eat, making food feel extra satisfying for them. And because of this, they find it difficult to control urges even when they know it's unhealthy or will cause distress later. Moving on to our last and psychological factor, we have perfectionism. So perfectionism meaning they have a disgustingly high or unrealistic standards for themselves, wanting to do everything perfectly and then feeling like any mistake is a failure. And in the context of BED or binge eating disorder, perfectionism often shows up as an extreme concern about their body image or their weight and their self control around food. And they may set strict rules for eating. For example, like they would say, one meal a day lang ko, di na ako mag-sweets. And then when they fail, when they fail to do that, they get completely disappointed and frustrated. They feel like a failure, even if they can't adhere to what they have set for themselves. So even when they make a small mistake, like eating what they have forbid themselves to eat, they would feel completely frustrated. It's like all or nothing mindset. So which can lead to a loss of control and binge, leading to binge eating. So they would say like, nakasugod naman ko kaon, ako lang padayonan. It's like all or nothing. And after binging, again, they would feel intense guilt, shame, and they would self-criticize, which reinforces their low self esteem and emotional distress. And over time, this cycle of trying to be perfect, leading to failing, and then feeling guilty, and then binging again. Okay, now moving on to our environmental factor. First, we have our family environment. Now, the family plays a big role in shaping a person's attitude towards food, your body image, and your self worth. And when the family environment is critical, or controlling, or emotionally imbalanced, it can increase the risk of developing unhealthy eating behaviors such as binge eating. And a few patterns could include like as simple as critical or judgmental attitudes about your weight or your appearance, or family members who constantly comment on a child's body or their weight and eating habits can make them feel ashamed and insecure, which leads to low self esteem and the use of food as a coping mechanism for emotional pain. And family relationships are tense or distant, individuals may feel more lonely and stressed or unloved, and they may tend to turn to food to fill the emotional emptiness or to calm themselves. Now, if the family environment also has models unhealthy behaviors, like if your parents or your sibling has diet that's excessively about binge eating, and they tend to criticize their own bodies, the children or even the members of the family can imitate those same behaviors. Now, next we have our dieting or restrictive eating patterns. So, strict dieting or avoiding certain foods completely may seem like a healthy choice at first. However, it can actually trigger your binge eating later on. Now, when a person tries to restrict themselves from food or like restricts themselves from having too much food intake, the body may respond in ways that make binging more likely. So, first, you are physically deprived. Your body doesn't get enough calories or nutrients, and this causes strong hunger and cravings, especially for high calorie foods, which are most probably the foods that you forbid yourself to eat. And eventually, you give in and eat large amounts of food all at once. And then there's also psychological pressure where you constantly think about what not to eat can make food even more tempting. And when they break the diet by eating one restricted item, they think that they've already messed up. So they might as well eat everything now. It's like all or nothing mindset. And then there's also emotional rebound, which um as dieting can cause irritability. Like when we're hungry, we tend to get very pissed, we get hangry, and then there's also stress, and then there's also it can affect your mood. And then when your emotions get intense, you tend to turn to food for comfort again, resulting in emotional binging. And the cycle just keeps repeating and repeating. And after after binging, again, just like the others, you feel guilty and frustrated. And then you would vow to diet harder next time, but then it just increases your restriction. And then another binging happens. So this just becomes a repeating binge restrict cycle. Next, we have our cultural and media pressure promoting thinness or ideal body image. So, in today's society, many cultures, especially those influenced by Western media, they place a high value on being slim, having a so called perfect body. Now, so people are constantly exposed to images of thin models, of thin influencers and celebrities who are portrayed as beautiful and successful and happy, perfect, and amazing. This kind of media exposure and social messaging can make people think that, especially young people, it can make them feel that they must look a certain way to be accepted or loved. And as a result, they can develop body dissatisfaction and low self-esteem, which are our major triggers for our binge eating. Basically, you compare yourself to this ideal body standards that you see in social medias, and then you start believing that, oh, you're too fat or you're not attractive enough, and then you achieve this ideals by engaging in strict dieting or food restriction, which leads to worsened hunger and cravings. And when you can't maintain the strict or your diet, you binge out your frustrations or guilt. And that failure to meet these body standards that you set for yourself causes feelings of failure and shame, frustration, dissatisfaction, which reinforces the binge restrict cycle again. So remember, guys, we are all unique in our own way, and that's what makes us special. Okay, moving on. We have peer influence and social comparison. So your peers, your classmates, your friends, your coworkers, or your mutual friends on Instagram, they play a big role in shaping how you feel or how a person feel about themselves and their own body. And when you're surrounded with people who constantly talk about dieting or weight or appearances, a person may start comparing themselves and feel like they don't measure up. This comparison can lower one's self esteem, increasing body dissatisfaction, which are strong emotional triggers for binge eating. So, the person may compare their body size or their eating habits to their peers or social media figures. They may feel less attractive or less disciplined because they don't have the same diet as that one influencer that you follow on Instagram, and creating feelings of inadequacy or shame. And there's also friends who are obsessed with dieting or clean eating. This can unintentionally pressure others to follow unrealistic food rules. And when the person fails to keep up with these rules, they may binge eat secretly out of frustration or guilt. And then there's also bullying or teasing, as it is quite common to be bullied and teased because of your weight or appearance, which can cause emotional pain and loss of confidence, of course. And food may become your source of comfort or emotional escape. which would lead to social isolation, which is um, there would be a fear of judgment or rejection, which can make a person avoid social eating situations, leading to secretive eating or nighttime binging. And next, lastly, we have easy availability of high calorie or comfort food. So those with a lot of money, they're very vulnerable to this. They're susceptible. So since today high calorie or sugary foods, fast foods such as chips, cakes, soft drinks, they're everywhere, right? In stores, in online delivery apps, even at home. And these foods, they're cheap, they're tasty, they're good, and they're easily accessible, making it tempting to overeat, especially when a person is stressed or emotional. So for people who are vulnerable to binge eating, this constant exposure to triggers uncontrollable cravings and episodes of overeating even when they aren't hungry. You're lucky if you're broke because you don't, even if you're exposed to such accessible foods which triggers binge eating, you don't have the money to buy it. Therefore, you're lucky. Now, this constant temptation, such as seeing or smelling foods frequently, it could be a snack at home or it could be the ads online, this can make a person crave it more
Oh my
often.
god.
Now, for people vulnerable to binge eating, this constant exposure can trigger uncontrollable cravings and episodes of overeating, even when they aren't hungry. So there's constant temptation. And this constant temptation, such as when smelling or even just seeing foods frequently, this can make a person crave it more often, which can lead to a habitual or impulsive eating, even during, especially during stress. And these foods can become your emotional comfort. Your comfort food is what we call it. And then as these foods, this works by activating the brain's reward system through dopamine release, giving temporary pleasure or relief from sadness or boredom. And over time, the person learns to rely on these foods for emotional comfort instead of healthy coping methods. And easy access to foods can make it simple to eat large portions without realizing it, like eating straight from a bag of chips while watching TV. And this encourages loss of control and larger binge episodes. And after binging, again, as what I have been repeatedly mentioning, after binging, people usually feel guilty. The guilt sets in, the person promises to stop or to swear that next time I'm really going to resist it. But because the food is always available, it's always there, everywhere you turn, everywhere you look at, oh, there's food, then your cravings would return, which would lead to another binge. Now, all these factors would then lead to our binge eating disorder. Now, our binge eating disorder, of course, it comes with consequences. So we have functional consequences. It is divided into our psychological, emotional consequences, our health related consequences, and our social consequences. Now, starting off with our psychological, emotional, no, yes, our psychological, emotional consequences. Of course, we have poor self image or low self esteem. Now, people with binge eating disorder, they often feel dissatisfied with their bodies or they see themselves as weak for not controlling how they eat. So, this constant self criticism damages their confidence and self worth. So, they develop consciousness with how they look and their confidence just decreases. And then there's also feelings of guilt, shame, or disgust after binging episodes, which has been repeatedly mentioned. After binging, um, individuals commonly experience strong negative emotions, such as guilt, that they feel like, oh, I shouldn't have eaten that much. I shouldn't have bought this, stuff like that. And shame. They feel ashamed because they couldn't control themselves. They can control their cravings. Um they can stop themselves from eating even if they're not even hungry at all. Or they might feel disgusted. And these emotions can just further worsen their binge eating episodes because again, stress or anxiety is a trigger for binge eating. And then there's also anxiety and depressive symptoms again, as it is strongly linked with our mood and our anxiety disorders. So binging may temporarily relieve stress or sadness, but then afterwards, it often increases your depression and your anxiety, creating a vicious emotional cycle. And then there's impaired quality of life and life satisfaction. The emotional burden or guilt and social withdrawal, which is caused by binge eating disorder. This can interfere with work, your school, or your relationship with others. And the person with this disorder may avoid social events that involves food and feel overall less happy and fulfilled. And then there's social isolation. Because of embarrassment about their eating behaviors or weight, many avoid eating in public or spending time with the others, leading to loneliness and reduced social support. And then there's also a loss of control and emotional distress, as during a binge, people often feel that they're unable to stop. They may even realize it while eating, while binge eating. But then this loss of control increases emotional and pain and frustration. So even if they're aware that I'm gonna regret this later, or oh, I shouldn't have done this, for sure I'm gonna regret this, they still can't do anything about it because they don't feel like they are in control. They don't have a sense of control with their own urges. Now, we also have body dissatisfaction and perfectionism. So this constant comparison to others, as mentioned earlier, this pressure to meet certain ideal body standards, this worsens their negative self-image and emotional distress, which would then lead to binge eating. Exactly. Now, moving on to our health related consequences, of course, binging, eating a lot of unhealthy foods, processed foods, high fat foods, low fiber foods, of course, it would lead to health consequences. And first, we have our weight gain and obesity. So, because of frequent episodes of binges or of overeating large amounts of high calorie foods, people with binge eating disorder, they often consume more calories than their body can use. And over time, this leads to significant weight gain and obesity. And obesity itself becomes a major risk for other diseases, such as, most especially, heart problems or diabetes and joint pain. Now, speaking of, we also have increased risk of metabolic disorders. We have type 2 diabetes mellitus, hyper, excuse me, hypertension, and, excuse me, dyslipidemia. So, this constant overeating, especially foods that are rich in sugar, because what does sugar does again? What do sweets do again? Yes, they increase your serotonin temporarily, making you feel good for a short period of time. So these foods that are rich in sugar and unhealthy fats, they disrupt your body's normal metabolism. So this can cause insulin resistance, leading to your type 2 diabetes. And extra body fat also increases your blood pressure. And this also causes abnormal cholesterol levels, which leads to dyslipidemia, which raises the risk of heart diseases and stroke. Now, next we have gastrointestinal problems. You may feel bloated or constipated, you might feel acid reflux, or you might have irregular bowel movements, as eating large portions of food at once stretches your stomach, which then lowers your digestion, causing bloating and discomfort. And irregular eating habits and low fiber diets can lead to constipation. Why? Slow transit, slow gut motility, and frequent overeating, especially fatty or spicy foods, it increases your acid reflux, heartburn, and again, as mentioned earlier, it also causes irregular bowel movements, as this may occur due to alternating overeating and restrictive eating periods. And then next we have sleep disturbances. So people who have binge eating disorder or people who eat large portions of food, they may feel um, a shortness of breath upon exertion, or they may snore when they sleep, or they may experience sleep apnea, as this extra fat around your neck and chest can narrow your airways, which leads to your snoring and your apnea, sleep apnea, which are temporary pauses in breathing during your sleep. And this causes poor sleep quality, such as when during daytime you feel tired or daytime fatigue, and sometimes shortness of breath during physical activity. And poor sleep can worsen your hunger hormones, making binging more likely. And then we have our musculoskeletal problems, such as uh, back pain, or joint pain due to the excess weight. Diba? Since binge eating is actually usually more common in obese people. But they're not necessarily, just because they're obese doesn't mean, oh, they binge eat. Not necessarily. But usually, people who binge eat become obese, of course. Now, it causes musculoskeletal problems as they carry excess body weight, right? Which puts increased pressure on weight bearing joints, such as your knees, your hips, your spine. And over time, this can cause chronic pain, inflammation, and limited mobility. And physical discomfort may further reduce your activity levels, promoting more weight gain. And then we also have increased morbidity and mortality. So, the combined effects of obesity, your heart diseases, your hypertension, your diabetes, they lead to a higher rates of illness and mortality. And without treatment, if this doesn't get treated soon, your binge eating disorder can significantly reduce your life expectancy and overall health. Now, moving on, we have our social consequence. So, First, we have difficulty maintaining relationships. Individuals with a binge eating disorder often experience embarrassment, right? Embarrassment or shame about their eating behaviors or their weight. And they may hide their eating habits or avoid social gatherings involving food. And this secrecy and withdrawal from food can lead to misunderstandings, emotional distance, or even conflicts with your friends, your partners, or your relationships overall. So this makes it hard for a person with BAD. It makes it hard for them to maintain relationships. And then we have impaired social functioning. So as mentioned earlier, BED can cause low self-esteem. And because of low self-esteem and body dissatisfaction, people with binge eating disorders, they may avoid social interactions or public places where they feel like they're being judged for their appearance, for how they look. And this results in social isolation. It reduces their confidence even more, it worsens it, and difficulty forming new relationships and participating or engaging in group activities, therefore impaired social functioning. And then it also causes decreased productivity, poor work, or academic performance. So these stress that you experience, your emotional distress, your fatigue from poor sleep, your guilt after binge eating episodes, all these can affect your focus and your motivation, as well as your energy levels, right? And as a result, your performance at work or at school may decline. This could cause frequent absences or lack of concentration during discussions or lectures. It can impact your academic progress or your work stability if you gotta work. Next, we have reduced participation in recreational or physical activities. Now, due to body shaming, which is very common even in today's time, there's fear of judgment. They feel like when they go out, you're going to be judged by people. They're going to be looked at. They're going to think that people thinks of them as, disgusting. And due to this, due to the body shaming, due to a fear of judgment or physical discomfort from excess weight, many people with binge eating disorder withdraw from engaging in recreational or physical activities such as sports or their hobbies or outdoor activities that they once enjoyed. And this loss of participation furthermore decreases their overall quality of their lives. And this reinforces feelings of isolation and lonehood. And then, what do? Since they're stressed and they feel unhappy and they feel isolated and they're judged and they're distressed, who do they turn to? Nobody, because they're isolated from people. And they're isolated from people, they're lonely. And they're lonely, they're sad, and they turn to food for comfort, which then just worsens their binge eating cycle. So it doesn't help them get better. Now, these consequences leads us to our DSM. So in our DSM here, we can see that it is characterized by our first diagnostic. Hold on. So here, so there's recurrent episodes of binge eating. So this means that binge eating happens repeatedly, not just once in a while. And to diagnose it as binge eating episode, two things must occur together. And these are eating an unusually large amount of food in a short time. So this means eating much more than most people usually do. And like finishing a whole pizza by yourself or a tub of ice cream by yourself and the snacks all within 2 hours. And it's not just during holidays. No, it's not occasional. It happens in everyday life. And then second would be feeling a loss of control during the episode. When you're eating, during a binge eating episode, a person may feel like they can stop or control how much they're eating. And it's like an urge that takes over. And even if they want to stop, they can't. That's for our first criteria. Next, we have the binge eating episodes are associated with three or more of the following. So we have they eat much more rapidly than normal. So they eat very fast. They often without chewing their food properly or taking breaks. And then they eat until they feel uncomfortably full. You ever experienced feeling comfortably full? That's very uncomfortable. And even if people with BED, even if they feel uncomfortably full because they're really full, they still continue to eat even when they feel stuffed or in pain. And then there's also eating large amounts when not physically hungry. So even if they're not hungry, their eating isn't driven by hunger, and it's by emotions or sadness or even boredom. And then there's also eating alone because of embarrassment. So some they hide their eating because they feel ashamed of how much they consume. And then there's also feeling disgusted, depressed, or guilty afterwards. So after binging again, and what has been repeatedly mentioned, after binging, people with BED often feel self hate, sadness, or guilt about what they have just done. And then we have our marked distress regarding binge eating. So the person may feel very upset or troubled about their binge eating, and they may worry about being out of control of their weight or their behavior. And for the frequency of binge eating, the binge eating happens at least once a week for 3 consecutive months. So this helps differentiate an occasional episode and a lasting disorder. So if it lasts for 3 months and once a week, at least once a week for 3 months, then that would be considered as a binge eating disorder. And unlike bulimia nervosa, binge eating disorder does not have any compensatory behaviors. People with bulimia, as we know, they binge eat, but then they try to undo it by vomiting, purging, or fasting or exercising excessively. But in binge eating disorder, there are no such behaviors. They do not compensate at all. So the food stays in the body, which may lead to weight gain over time. And then the remission status. In partial remission, this tells how the condition is currently behaving. So in partial remission, they used to binge frequently, but now it happens less than once per week for a while. That's in partial remission. And in full remission, they no longer meet any of the binge eating criteria for a long period. So this helps track the recovery progress of the person. And the severity, based on frequency, it shows how severe the disorder is, depends on how often the binge episodes happen. So if it happens, excuse me, if it happens 1 to 3 times a week, it will be considered as mild. If it happens 4 to 7 times a week, it will be moderate. And if it happens 8 to 13 times per week, that will be severe. And it will be characterized as extreme if it happens 14 or more times a week. So the frequency of your binge eating disorder or one's binge eating disorder, this helps professionals decide on their treatment intensity, like therapy, their medication, or nutritional counseling. Now, binge eating disorder basically is diagnosed when a person is eating large amounts of food uncontrollably, they feel emotionally distressed about it, they don't use any purging methods such as exercising excessively or dieting, and then they experience this pattern for 3 months. Now, moving on, this now then leads to our nursing DX of what is it? Ineffective coping related to poor impulsive control as evidenced by recurrent binge eating despite negative consequences. So now, this diagnosis for binge eating, uh, it's about having recurrent binge eating despite your awareness that it's a maladaptive coping pattern. So this diagnosis highlights the ineffective coping strategy of an individual, which is the binge eating, and the underlying problem, which is the poor impulse regulation. Now, for our nursing management for this, we have first establish a trusting and non-judgmental nurse-patient relationship. Of course, a supportive environment is what we need. An environment that would encourage them to open or express what they feel about their eating behaviors, and without the fear, of course, without the fear of criticism. We should be the ones that would make them feel more open without being judged. That would they allow to feel vulnerable. People that they would feel vulnerable with, and uh, trust that allows we would gather the trust that would allow nurses to explore emotional triggers behind their binge eating and promote insights into more healthier coping patterns. And then next is encourage verbalization of feelings such as stress, their anxiety, their guilt, or shame, rather than suppressing them. Of course, everybody feels better when expressing their emotions, and expressing their emotions through talking rather than eating helps reduce tension and teaches them healthier emotional release. It also allows the nurse to identify the underlying stressors that is contributing to their binging behavior. And then we also have identify specific triggers or situations that precede binge episodes. So you've built trust. Now you recognize the triggers, like is it stress, is it loneliness, or is it perfectionism? This helps the patient gain awareness of the binge emotion connection. And awareness is the first step towards breaking the cycle and developing healthier coping methods. And then we have teach and encourage alternative coping strategies. It could be relaxation techniques, journaling, physical activity, deep breathing, or creative outlets. So providing this is through providing positive outlets for emotional release, which replaces the maladaptive habit of binge eating. So this would help improve their self-control and their impulse regulation, and empowering the patient to respond more effectively to stress. And then we have involve the patient in setting realistic and achievable goals for behavior changes. So collaborative goal setting promotes self-responsibility and motivation, and it helps the patient regain a sense of control, countering their feelings of helplessness and low self-esteem. And then we have encourage balanced meal planning with the help of a dietitian. This structured and healthy eating patterns prevent them from excessive hunger, and which can trigger the binge episodes. And a non restrictive balanced diet would support both physical and emotional stability. And then we have providing information about available support groups or counseling. So, examples of these are CBT or our behavioral therapy. And CBT, it helps the patient identify distorted thinking patterns, such as how their perceptions about their behaviors, and like their all or nothing behaviors mentioned earlier. Like if they um, commit or commit one error of their restrictive diet that they've set for themselves, they would then say, "Oh, so na, so might as well just finish it all." So this thinking pattern would be converted and to would be replaced by something realistic and with compassionate thought. So group providing information about group supports can reduce their feelings of being isolated and would reinforce recovery, knowing that there are also other people that are experiencing the same struggles as them. And then reinforce progress and positive coping behaviors, recognizing their small improvements enhances their self efficacy and encourages them to continue their healthy habits. And it shifts focus from guilt to self acceptance and growth. Now, moving on to our medical management. First, we have our lisdexamfetamine. Lisdexamfetamine. So this medication is the only FDA approved medication for moderate to severe binge eating disorders in adults. It is a stimulant which is originally used for ADHD, and it works by helping reduce the binge frequency by acting on dopamine and norepinephrine pathways in the brain, which results in improved impulse control, focus, and reward regulation. This reduces the urge to binge and increases the ability to delay gratification. And then we have our SSRIs. Examples are is our fluoxetine and our sertraline. These are our selective serotonin reuptake inhibitors, which are antidepressants, which are commonly used to manage mood and anxiety disorders. And these SSRIs, they help stabilize serotonin levels, which are often low in our binge eating disorder. So SSRIs, they improve mood, they reduce anxiety, and they decrease your compulsive eating urges, which breaks the emotional binge cycle. And they also improve coexisting depression and body image distress. Gosh, sorry. And then we also have our behavioral and then also we have our behavioral weight loss. So this behavioral weight loss or BWL, this focuses on gradual, healthy and sustainable weight reduction. Through this is done through um, proper diet, exercise, and lifestyle changes with the guidance of a professional. So this promotes structured eating patterns. This prevents restrictive dieting, and this enhances self-monitoring skills. So it focuses on your health rather than your perfection or appearance, and it reduces emotional triggers and supports long-term recovery. And then we're quite familiar with this one. We have cognitive behavioral therapy or CBT. So it's a um, structured form of psychotherapy that it helps individual identify and change their negative thoughts and patterns and behaviors that is associated with binge eating. It is most effective. CBT is most effective. Psychological treatment is the most effective psychological treatment for binge eating disorder, as it helps the patient to develop regular eating patterns and avoid extreme hunger. And it helps them to monitor their eating habits themselves and increase awareness and control. So they learn through CBT, they learn um, self control and other coping techniques for emotional triggers. They also develop practice problem solving skills to manage their stress without turning to food and help them address their way of thinking um, that would worsen how they feel or how they see themselves. Next, we have dialectical behavioral therapy. So this therapy is originally developed for emotional dysregulation, but it is now used to treat binge eating disorder. It combines mindfulness and behavioral change strategies. So your dialectical behavioral therapy, it targets your poor emotional and control and impulsivity, which are our key issues in binge eating disorder, right? And it includes mindfulness, such as increasing your awareness, your thoughts, your emotions, and your hunger cues, which helps individual to eat more consciously. And it also includes distress tolerance. So it teaches an individual how to handle strong emotions or stress without resorting to binge eating immediately. And then emotional regulation, which helps them recognize and manage their emotional triggers effectively, which overall replaces binge eating with a healthier emotional response. And with all these interventions, our expected outcomes is that the patient would report a decreased frequency of binge eating. um, Expected outcomes. Hello? Oh, as I was saying, all these interventions, when all of these are done, are expected outcomes for this would that the patient or the person would report a decreased frequency of binge eating episodes. So the patient would share that their episodes of binge eating occur less frequently and that they are more aware of their triggers and they can pause before acting on the urge to binge. As a decrease in their binge eating episodes would show that they are gaining control over their impulsive eating behaviors and they are learning to manage their emotional distress without immediately resorting to food. So, this progress would reflect that they have improved self regulation and have developed a sense of empowerment over their eating habits. Next, we have demonstrates balanced eating habits by consuming regular, portion controlled meals without episodes of uncontrolled eating. So, with this, the patient would now then eat at regular times, would choose balanced meals that include all food groups, and they consciously manage portion sizes and no longer feel the compulsion to overeat. So, this establishes a consistent and portion controlled eating that helps them restore normal hunger and fullness cues, your leptin and your ghrelin. What does your leptin do again? It's your I'm full signal. Your ghrelin is your I'm hungry signal. And then verbalizes improved sense of control over food choices and reduced urges to binge. So the patient will express greater confidence in making healthy food decisions and reports fewer intense cravings or emotional triggers to binge. And then uh, they would express healthier self-esteem and a more positive body image with fewer negative or self-deprecating jokes about their weight or appearances. The patient would speak more We expect the patient to speak more kindly about their body and avoid self-critical remarks. They would demonstrate a sense of acceptance and appreciation for their body's value, and that is beyond appearance. So how they see themselves, improve self-esteem, body image, these are vital to recovery, as negative self-talk or self-deprecating jokes and shame, this often fuels your binge eating episodes. And by fostering a positive self-view, the patient would start to build emotional resilience and would reduce emotional triggers that is linked to overeating. And then we have effectively uses non-food coping mechanisms such as relaxation, your journaling, your walking, when they're experiencing stress or negative emotions. So it is important that they learn healthy ways to cope with stress to help them break the association between emotional discomfort and food. And this behavioral shift actually supports them in long term emotional stability and would, in a way, help them turning back, would help them prevent from turning back to relapsing into their binging patterns. And then lastly, they would report feeling supported and less isolated. So the patient would express that they feel understood, that they feel encouraged by their family or their friends or their support groups. And actually, their social support, it plays a major role in the recovery as they're the ones that can provide them with emotional reassurance and accountability. And feeling connected helps the patient combat isolation, which would help them boost their self worth and strengthens their motivation to maintain healthy habits. Now, that would be all for our report about patients with eating disorders.
Okay.
Thank you.
Thank you. Wait. Hello. Thank you so
Hello.
much.
Thank you so much, Gwen.
Thank you so much for listening, everyone. Thank you. Good night.